Some of you are medtechs, no, as your pre-med, so I hope madali na lang to and you're familiar with this lecture. So to begin with, this is the outline of our lecture. We will be discussing the different principles and procedures in the basic CBC or the routine hematologic test, such as the CBC, as well as the blood film examination and even the bone marrow examination. Okay, so why is it important to discuss or to know the basic principles and procedures of hematology? So this is of course important. No, as you can see, all of our patients, so pag nakikita natin, we always ask for a routine CPC, no, for all our patients, kahit na anong case, anong patient. So under the of course, this is because our CBC or hematology test is central to diagnosis and management of hematologic diseases. And as you know, hematologic diseases is very broad, and from anemias to leukemias and even metastatic tumors. Now, so for the hematology, under this, we will discuss hemoglobin, hematocrit, the RBC indices, our manual blood cell counts, even the instrumentation. So as we develop the different tests, now using mga high-tech na mga instruments, and also the physiologic variations, and even the erythrocyte sedimentation rate. Okay, so what is hematology? So of course, hema comes from the word, I think it's a Greek word, hema, which means blood, and of course, logiology is study. So this is study of blood cells and coagulation, and this includes the analysis of the concentration of the different components, the structure, the functions of the different cells in the blood, precursors in the bone marrow, as well as the chemical constituents in the plasma or serum linked with the blood cell structure and its function, as well as the function of platelets and proteins in coagulation. And with the advanced technology, we can now even detect several genetic mutations that can lead to hematological diseases. Okay, so we will start with hemoglobin. So I know you're all familiar with this. So this is the main component of our red blood cells, and this serves as the vehicle, no, for the transport of our oxygen and carbon dioxide. So that 1 gram of hemoglobin holds about 1.34 ml of oxygen, so that for an adult with 600 grams of hemoglobin can hold up to 800 ml of oxygen. So our hemoglobin, when it's dissociated, is composed of 2 pairs of our globin chains and the 4 prosthetic hemes. So also it's important to take note of the 4 different hemes. So this is for the adult heme, which is composed of 2 alpha and 2 beta chains. And then, of course, the main function is to transport oxygen from the lungs. And in the lungs, it has a high oxygen tension, thus allowing the exchange of gases, about 95 to 98%. But in the tissues, it has a low oxygen tension, thus the oxygen will go to the tissues. Now, we have different types of hemoglobin, and we have here the reduced hemoglobin, which is the hemoglobin with an associated oxygen, and the iron here is in the ferrous state. Another type is the oxyhemoglobin, in which each group is associated with 1 molecule of oxygen. And the iron here is also in the ferrous state. While for the methemoglobin or the hemoglobin, the iron here is oxidized to the ferric state, and the molecule loses its capacity to carry oxygen or carbon dioxide. So what is anemia? So this is defined as a decrease below the normal of the hemoglobin concentration, the RBC count, or the hematocrit. So especially when you encounter patients, and even layman, they have this notion that anemia is will decrease in their blood pressure, but you have to correct them that anemia is represents our red blood cells. So this is a common, frequently, or a complication of other diseases. And the correct hemoglobin estimation is important. Minsan, lalo na pag nandun tayo sa mga barrio or far-flung areas wherein CBC or diagnostics is not readily available, and we rely on the PE, no, like for example, the skin color of our patients or the visible mucous membranes. Ito yung ginagawa nating criteria to diagnose anemia, but according to our literature, it is highly unreliable. So it's really important to do our hemoglobin check. Now, for the hemoglobin derivatives, we have the following. So we have mentioned the hemoglobin or the methemoglobin. So in here, this is a hemoglobin derivative where the iron in the ferrous state is oxidized to the ferric state, so that when it is converted to this hemoglobin, it is unable to combine reversibly with oxygen. This is seen among normal individuals up to 1.5%, but when it is increased, it can cause methemoglobinemia. And this causes a chocolate brown discoloration of the blood, cyanosis, and functional anemia. Okay, so this results also from the increased production of your hemoglobin or decreased the NADH cytochrome B5 reductase activity. It can be hereditary or acquired. Another form of methemoglobinemia is the hemoglobin M, which has an abnormal hemoglobin molecule with intact RBC reducing systems, or which is hereditary. Another derivative is the sulfhemoglobin. For this, it is a mixture of oxidized, partially denatured forms of hemoglobin that forms during oxidative hemolysis. So during the oxidation, the sulfur is incorporated into the heme rings of the hemoglobin, resulting now into a green hemochrome. So that further oxidation will lead to the denaturation and precipitation of hemoglobin, known as Heinz bodies. So a soft hemoglobin cannot transport oxygen also, and will combine with a carbon monoxide that will now lead to the formation of your carboxy soft hemoglobin. So in here, blood is colored mauve or lavender, and this is also seen or among patients who are taking sulfonamides or aromatic amine drugs, seen also in severe constipation. Those are infected with Clostridium perfringens, as well as enterogenous cyanosis. Another derivative is the carboxyhemoglobin. So ito yung nakikita natin sa movies, ano yung mga old movies, no, na um, associated with poisoning. So in here, normally we can trace carboxyhemoglobin in our blood up to 0.5%, but it is increased in hemolytic anemia with 210 times greater affinity to combine with carbon monoxide versus the oxygen, so that when it is in the form of a carboxyhemoglobin, it will not bind and carry oxygen anymore. So it can lead to shift to the left hemoglobin oxygen dissociation curve, leading now to anoxia, so absence of oxygen in our tissues. It is light sensitive, so that it will give you a typical brilliant cherry red color of blood. So during autopsies, when you consider carbon monoxide poisoning, you can see this brilliant cherry red color of the blood. Chief sources of this carboxyhemoglobin includes the following, no? So gasoline motors, illuminating gas heaters, defective stoves, tobacco smoking, so that it is has been described as hazards of modern civilization because this gas has been found in the air of busy streets of large cities. Okay, now we go to the different components of our um, hematology examination, so specifically the complete blood count. For first, we will tackle hematocrit. or also known as the packed cell volume. This refers to the ratio of our RBC volume to that of the whole blood. So it will reflect the concentration of red cells, but not the total RBC mass. Usually it is expressed in percentage for conventional units or a decimal fraction for SI units. So pag SI, we use the liter per liter. And for the anticoagulants, we used EDTA especially for our automation, for mga machines natin. But for our capillary tubes, this is usually contain dried heparin. The standard tube is about 5 ml, and it requires at least you mix it 8 inversions, so the figure of 8, also before you process it in the machine for CBC. For the measurement of our hematocrit, we can have a direct method or indirect method. So for the direct, we use this Winthrop or the Marrow method. So this one in the picture here, the upper right, but it is no longer used. Wala na rin ako nakitang Winthrop tube up to now. The next one is micro method. The picture under upper right. This is a heparinized capillary hematocrit tube, about 7 millimeters long and 1 millimeter bore. So we centrifuge this for 5 minutes at 12,000 grams. We can also compute for the hematocrit. So this is the indirect measurement using the MCV times the RBC count. We also have the rule of 3 for the hematocrit, hemoglobin, and RBC, but this is only applicable for normal conditions. For the interpretation of results, so the reference range, actually the reference range varies for every laboratory depending on our because we have a competition for this, no, and there are factors that affects kasi yung results natin. So like the ethnicity, yung body, ng patients natin. Of course, Caucasians and Asians have different conditions, so that this varies. But in general, we, and also for the literature's sake, we have this reference range. But as I've said, pwede siyang mag-vary among laboratories. So hindi to yung like this is na the normal value. Okay, so for the interpretation of results, of course, we have different reference range for males and females because of the different body types, and also for children and adults. So this can vary, and of course, lower than the normal value would be can be interpreted as anemia, and if it's increased, have polycythemia. The hematocrit is also unreliable as an estimate of anemia immediately after blood loss or immediately following transfusions. So, of course, when you request for hematocrit, especially, for example, your patient is a stab wound patient, and then nag-transfuse tayo ng pack red blood cells, sample 5 units. So you cannot request for hematocrit right away after the transfusion. So you have to usually wait up to 4 hours after requesting for hematocrit or CBC. So for the sources of error, we have the following. So centrifugation, we follow the adequate duration and speed for centrifugation of our hematocrit. We also have trapped plasma, which can be seen during centrifugation. This is a small proportion of WBCs, platelets, and plasmas that are trapped between the red blood cells. So this is seen in macrocytic anemia, spherocytosis, hypochromic anemia, and even in sickle cell anemia. For the sample can also be a source of error, especially when there is a prolonged application of tourniquet, so muscular activity. Example, we have strenuous exercises, and even posture, pag matagal kang nakatayo. Excess EDTA, there is an adequate ratio of your blood to your anticoagulant, so it can falsely decrease your hematocrit with the normal hemoglobin. Another one are technical errors, failure to mix the blood adequately before sampling, and also improper reading, because for the manual reading of hematocrit, we use a parang special type of ruler that will correlate the number of the volume of your red blood cells to that of the whole sample, and you can have your hematocrit and the corresponding hemoglobin. So we go to the next. We have the red blood cell indices. According, so Wintrobe is a person who introduced the calculations for determining the size, the content, and hemoglobin concentrations of red blood cells. This is useful, especially in the morphologic characterization of anemias. So in the peripheral blood smears, we have to characterize our the three cells, the red blood cells, the white blood cells, and the platelets. So it is important to get the RBC indices because this will give you a clue on the characterization of our red blood cells. So here we have the MCV, or the mean cell volume. So this is the formula hematocrit times 1,000 divided by the red blood cell, and this is expressed in femtoliters. The normal value of this is about 80 to 100 femtoliters, so that if it is less than 80, um, it can be categorized as microcytic anemia, and if it's more than 100, so mga macrocytic naman. We also have the mean cell hemoglobin, or the MCH, which is hemoglobin times red blood cells, and this is expressed in picograms. The third one is your MCHC, or the mean cell hemoglobin concentration, and this is formula is hemoglobin over hematocrit and expressed in grams per deciliter. This is increased. The MCHC typically increases only in spherocytosis because this is um, it resembles the maximum hemoglobin capacity of our red blood cells. And in a normal condition, our red blood cells will only hold the maximum amount of hemoglobin. But in case of spherocytosis, it can increase because of the abnormality in its structure in the cell membrane. The next one is our RBC count. So for the red blood cell count, we have here is the UNOPET. I don't know if naabutan nito for our medtechs here. So this is what it looks like. Meron siyang maliit na container with a fluid, and then yung with a tip, no, just a plastic tip wherein dito mo ilalagay yung blood and then you mix it together. So this is for counting red blood cells, WBCs, and platelets. So you charge it in the counting chamber. But another manual counting for red blood cells is using yung RBC pipette, the one with the red bead in the middle. So you dilute it also with a diluting fluid, and then you charge it in the Neubauer counting chamber. Another one is method is a semi-automated. So these are instruments that aspirate the sample and wash it out with a diluent. Um, so actually, we're not really using the semi-automated. So what we do now is the fully automated equipments that can run all of this, the RBC count, hemoglobin, hematocrit, and so on. The next important component of our CBC is the reticulocyte count. So these are immature, non-nucleated red blood cells. So I hope you are familiar with the maturation of our red blood cells. So before they are released into the peripheral blood, our red blood cells, sometimes when there's increase in the synthesis of our red blood cells, they are also released in the peripheral blood. So that this is what they look like. They contain RNA and continue to synthesize hemoglobin after loss of the nucleus. So we use a special stain for the manual reticulocyte count. We have the new methylene blue or the brilliant crescent blue. So under the microscope, they appear like this. They have this dark blue network, reticulum or filamentous strands, and with dark blue, two dark blue granules. So here. These reticulocytes are pale blue, and the RBC stain will stain pale blue or blue green. Okay. So the number of reticulocytes is determined in at least 1,000 RBCs. I have not encountered this one, the Miller disc, which is inserted in a microscope, and this will allow you to estimate the RBCs rapidly by imposing two squares in the field of view. This is the formula for our reticulocyte. So the number of retics in large squares times the number of red blood cells in the small squares times 100. And the reference range, so of course, mas mataas ang normal value for infants because they have their hematopoiesis is still active than the adults. For the adults, it's only 0.5 to 1.5, while for the newborn infants, it's about 2.5 to 6.5%. For the interpretation, it provides us an estimate of our red cell production. Okay. So this is a counting chamber, now the Neubauer counting chamber. As what I've mentioned, either you use the Unipet or the RBC pipette, so dilute it with the diluting fluid and the blood, and then you charge it in here. So under the microscope, this is what you will see, and you will count the number of cells. So depending on what are you counting. So if you want the WBCs, count from the squares, the A, B, C, and D. And for our red blood cells, we use the blue squares. And then for the green plus blue for the platelet counts. So in this area. So next is our WBC counts. So another term for our WBC is leukocyte. The specimen of choice is blood with anticoagulant using EDTA or the ethylenediamine tetraacetic acid. It says here that heparin is unsatisfactory as anticoagulant. So for now, we are mainly using EDTA anticoagulant for our CBCs. So for a manual method, this is occasionally used, and however, the medtech should still be, kasi nga we are equipped with machines na no, so fully automated equipments for running CBCs because of the high volume of request of CBC per day. However, our medical technology should still be able to perform manual counting of our WBCs. This is as a check on the validity of electronic methods for calibration purposes, and then also check for on validity for patients with profound leukopenia or thrombocytopenia. So in the lab, we use actually for so in the laboratory we have what they call this values that if it's below or above the normal values, we do manual counting of our CBCs. Then for blood specimens, also with platelet counting interferences such as microcytic RBCs, because they can be seen or read by the machine as platelets. And also as a backup method, pag nag-bag down yung machine natin sa laboratory, we will do manual counting. So to compute for the true leukocyte count, we have here the total count of WBCs times 100 over 100 plus the number of nucleated red blood cells. The reference value is about 4.5 to 11. Sometimes it's 5 to 10 times 9, 10 to the 9 per liter. Okay. The next one is the platelet count. So platelets are thin discs, about 2 to 4 microns in diameter and 5 to 7 femtoliters in volume. So they function in hemostasis, in maintaining the integrity and process of blood coagulation. And the visual method of choice is through a microscope and also the reference method. So this is what they look like under the microscope. So medyo bluish to violet color, and their sizes vary from 2 to 4 microns. So sometimes we can see giant platelets or large platelets. Yes. So do you remember where platelets come from? Anyone? Gising pa ba kayo? Hello?
Yes po,
Yes,
Doc.
we're still here.
Okay. So platelets come from megakaryocytes, right? And during the maturation of megakaryocytes in the bone marrow, um, nadidisintegrate yung cytoplasm niya. So paglabas niya sa peripheral blood, they will be seen as your platelets na lang. So nagkakahiwa-hiwalay yung megakaryocytes and they will appear as platelets. For the sources of error, you can have the following. So for our ECTA sample, it should be it should be processed no as soon as possible pagdating sa laboratory. And the viability will last up to 5 hours after collection at room temperature for 24 hours if you put it at ref temperature. But actually, this is not advised because of the pwede sila mag-aggregate and clumping. So it's really advised that you process your samples, especially for platelet count, as soon as possible. Another source of error is your imperfect venipuncture. So pag hindi mo na-heat agad yung blood, of course, yung mga platelets doon, pwede na mag-clump. And then delay in the anticoagulant contacting the blood. Pag hindi mo minix agad yung sample mo, once you put it in the tube, then some of the platelets will adhere to the tube and can cause a false thrombocytopenia. Another one is skin puncture technique. So of course, capillary blood gives similar mean values, but it has been reported that errors are more common in skin puncture techniques than the venous blood. And also, of course, delay in the sampling. We can also have falsely elevated counts of platelet when there are fragments of the WBC cytoplasm, especially in leukemia. So because your cells here are very fragile and these fragments of our WBCs can be counted as platelets by the machine. And we also have falsely low counts as seen in platelet satellitism. In here, the platelets will adhere to our neutrophils, and also this clamping can be due to agglutinins. Throughout my practice, once pala ako nakakita nitong the induced in vitro platelet clamping. So, though this is not really rare, no, parang meron talaga siya every now and then, so that you have to always check your slides under the microscope to check for the clumping of the platelets. Kasi under the machine, it will give you a low result, but under the microscope, may clumping lang pala or nag-aggregate sila. So you have to correct your results. And then spontaneous aggregation, incipient cutting due to faulty collection. So the reference range is about 150 to 450 times 10 to the 9, and the mean volume for the platelet count is about 6.5 to 12 centiliters among adults. Next, we have the ESR, or the erythrocyte sedimentation rate. This is a useful but non-specific marker of underlying inflammation. Okay, so in here, we use a well-mixed venous blood that is placed in a tube. So para siyang pipette. And then you secure it, parang nakakatayo lang siya, so that the red blood cells will tend to fall towards the bottom. And then the length of fall from the top column of the red blood cells, you measure that, and that is your ESR. So usually this is done in an hour, but with modern equipments, so this can be processed as fast as 30 minutes or 5 minutes pa yata. And um, most current tests that are being requested instead of ESR is our C-reactive proteins and even inflammatory markers. For here, it can even monitor cardiovascular diseases and metabolic syndromes. So we have also plasma factors that can affect our ESR results. So for elevated levels of fibrinogen, globulins like alpha 2, beta, gamma globulins, it can increase or accelerate our ESR. However, albumin and lecithin can decrease the ESR. It's also important to take note the zeta potential or the asymmetric protein molecules that decreases the negative charge of the red blood cells that tends to keep them apart so that a decrease in the zeta potential will promote the RELU formation or the stacking of coins, appearance of our RBCs. Red cell factors so that an anemia will have increased or accelerated ESR because of the change in the RBC plasma ratio that favors RELU formation. But for sickle cells or sclerocytes, because they have abnormal structures in their RBCs, this will give you a low ESR result. So that the ESR is directly proportional to the weight of the cell aggregate, but is inversely proportional to its surface area. The three stages of ESR are as follows. So the initial 10 minutes will give you little sedimentation as there is a formation pa lang ng rulu. But the next 40 minutes, the settling will occur at a constant rate. And then for the final 10 minutes, the sedimentation slows as the cell back at the bottom. So this is an example of our ESR. The most widely used method and the reference method as recommended by the ICSH is the Westergren method. And the anticoagulant here is a sodium citrate or the black cap. This is also what we call as the Westergren pipette. This setup is our modified Westergren. Kasi yung Westergren method, ito yung parang may kahoy siya na box. And then lalagay mo talaga yung babalutin mo itong pipette. Tapos isi-secure mo siya. Ipapatay mo siya 1 hour. For the modified, we can now buy this tubes na may ESR pipettes. So that it also yields the same result with EDTA. So you can use a black top or a purple top sample. Diluted with 0.5 ml of 3.8% sodium citrate. So another one that can give us the ESR results is the Vesmatic 20 instrument. So this is a completely automated benchtop analyzers that can analyze up to 20 samples at the same time. So results will be available in 25 minutes. But more current machines now, they're being incorporated in the CBC. So pag nag-request ka ng CBC, nandun na yung reticulocyte count and even the ESR. So I think that's this next. Another method is the micro ESR method, which is advantageous for our pediatric patients using only 0.2 ml of blood. So for the reference range, if the patient is below 50 years old, normal value is up to 15 for men and for women is 20. For above 50 years old, men is 20 and for women is 30 millimeters per hour, and above the age of 85, 30 for men and 42 for women. The sources of error are as follows. So elevated ESR when there is a higher concentration of the anticoagulant than recommended. Also, when you use heparin as anticoagulant, as it alters the membrane zeta potential, and when you tilt the tube. So dapat talagang naka-straight lang siya and hindi siya nagagalaw. Other factors, bubbles, hemolysis, cleanliness of the tube, and of course also temperature. So kung siya itatapat sa araw or sa light, because this will also affect the sedimentation rate. So minimum of 8 times inversion before the test is performed, and test should be set within 2 hours after blood collection at room temperature. For its application, so it is considered as one of the oldest laboratory tests, but it's still in use. Uh, so for the significance, this can be seen. This can be used to diagnose a sickle cell disease, osteomyelitis, stroke, prostate cancer, coronary artery diseases, also in pregnancy. Mark, this is also seen as markedly elevated when you have multiple myeloma, macroglobulinemias, severe hyperglobulinemias, and moderately elevated also with active inflammatory diseases such as rheumatoid arthritis, chronic infections, collagen diseases, and even neoplastic or cancers. If it's more than 100 millimeters per hour, so you should consider for patients with known cancer a metastasis. Now, we go to the instrumental technology. So, for you to understand how our machines are able to give us results, no, for our CBC. So, their principles are as follows: we have electrical impedance and radio frequency conductivity. So, I think we have four. So, for electrical impedance, in here, the cells will flow through an aperture. So parang papasok siya sa maliit na tube, and as it flows there, it will cause changes in the electrical resistance, and these are counted as voltage pulses. So these voltage pulses will give us an idea kung the size or the weight of the cell. Okay, so this is um, the Coulter principle is comes from. So that Coulter counts the pulses which are proportional in height to the volume of the cells, and this is the basis for the determination of blood cell histogram. So for our medtex here, so in our machine, no, you can see the different histograms for every CBC result, and I hope you know how to interpret them. Another one is the radio frequency conductivity. So for this one, they use a high frequency electromagnetic probe, and it provides information on cells, the internal constituents by permeating the lipid layer of the cell membrane. So for this, it can give us the chemical composition, the nuclear characteristics, and the granular characteristics of our cells. Another one is the light scattering. So we have the electro-optical analyzers. This is an example of an electro-optical analyzers so that it uses a light-sensitive detector that measures the light's scattering. The size of the pulse detected is proportional to the size of the particle. So this light scattering is being used in combination with electrical impedance. Okay, so this is what I'm saying earlier. So yung cells, for example, nasakshas sa machine, they will go through a narrow tube. And once they enter the tube, so since may resistance yan, the higher the resistance, the greater also is the size of our cells. So madidetect mo na yung size. Another one to help us determine the size would be the light scattering. So we have a forward scatter, which will, or the 0 degree forward, which helps us able to determine the size of the cell. And then we also have the 10 degree forward, side scatter. So this one will tell us the complexity or the cell structure of these cells. So it can, from the impedance, masasabi niya if it's a platelet, RBC, WBC, and then for the forward and the light side scatter, specifically the side scatter, it will tell you what type. For example, it's a WBC, it will tell you if it's a neutrophil, lymphocyte, monocyte, and so on. Now, another principle is the cytochemistry. So this is unique to the Bayer automated hematology, and it utilizes the cytochemical reaction to determine the peroxidase activity of our WBCs. This is specifically important for for differential diagnosis of our hematological na mga abnormal cells, like for leukemia versus a leukemoid reaction, and so on. Okay, so this is an example of our histogram, or also known as a scattergram. So this is what you see in a CBC machine. Okay, so in this graph, we have here on this side is the size. It will determine the size of the cell, and here is the complexity of the cell. So this is the forward scatter and the side scatter. So for this, for these cells, no, so they are smaller. So as you go here, it will increase in size. And also for the complexity, so pag nandito pa lang siya sa start, so mas less complex yung cells, and as it goes for to the right, it's more complex or it has granules. So for this, this is probably our lymphocytes, and this is a WBC, so this is would be the lymphocytes, and then this would be our neutrophils. In this table, we have the potential causes of erroneous results with automated cell counters. So here we have for the WBCs, increased, and there's heparin, monoclonal proteins, depleted RBCs, and so on. Causes of decrease are when there's clotting, smudge cells, and uremia. So on. So for red blood cells, they're increased if we have giant platelets, cryoglobulins, high WBCs, and decreased with clotting, hemolysis, microcytic red cells. Okay. Now we go to the blood film examination. So what does this cells look like under the microscope? So first is the examination of wet preparations. So in here, we just examine a fresh blood under the microscope. So why is it important to check for wet preparations? So this is to avoid artifacts of fixation, drying, and staining. That can be confusing when you read for a peripheral smear. So in here, we use a small drop of blood that is diluted with NSS, and then you cover it with a glass slide, and then you examine them under the microscope. So this is what you see under the microscope. So for here, these are just red blood cells. And it's important also to do wet preparation, especially when you consider sickling and spherocytes, because pag na-stain na kasi yung slides natin, you can have artifacts, no? You can even see sickling and spherocytes even in normal patients. So that's why it's through wet preparations, you can already see them here without these artifacts. Now for the examination of blood film, this is an important part of hematological evaluation. The reliability of information depends heavily on well-made and well-stained films. So they should be systematically examined, should be prepared as soon as possible. And we have 3 methods for the preparation of our smears. The first one is the wedge method. So in here, you drop 2 to 3 millimeters diameter drop of blood. Then you place about 1 cm from the end of a clean, dust-free on a flat surface. Then you use another slide. You make a 30 to 45 degree angle. Then you sweep it to the end of the slide, so that a good film should have a thick portion here and a thin portion with a gradual transition from one another that is free from ridges, waves, or holes. And we label our slide with the lead pencil if it's a frosted end, or pag hindi frosted, then we can also write here in the thicker end of the blood film. Another one is the cover glass method. In here, we use 2 cover slips, no? So touch the cover glass to the top of the small. So you drop here in a cover slip, then you put another cover slip. Once you slide it down crosswise on another cover glass, then the blood will spread evenly and quickly in a thin layer between the 2 surfaces, just like this. But this is not commonly performed. Another one is the spinner method. So in here, we use equipment It combines the advantage of easy handling or the wedge method and the cover glass method because in here there is a uniform distribution of cells. So for the spinner, you will have a uniform blood film with a monolayer of randomly distributed cells. For the blood stains, we use aniline dyes. So the basic dyes for our nuclei, the methylene blue and eosine for the cytoplasm. We also, the best and known methods is using the GEMSA and Wright stain. So for the Wright stain, we use a methyl alcohol of eosine plus the thiazines and the 10 to 25% azure B and other derivatives. For the staining problems, it can be excessively blue or excessively pink. So excessively blue can be because you have thick films, prolonged staining time, inadequate washing, too high alkalinity of the stain, and when the RBC up in here, if it's excessively blue, the red blood cells appears green or blue in comparison with excessively pink. It can be bright red or orange. The nuclear chromatin will become deep blue or black, while for the pink will become pale blue, and the granules will be deeply overstained, appears large and prominent. And for the eosinophils, it's difficult to identify them because their granules will become blue or gray. In comparison to excessively pink, they will have sparkling bright red. Another one is the film precipitates, no? Because this can be due to unclean slides, drying during the period of staining, inadequate washing, inadequate filtration of the stain, and permitting dust to settle on the slide or smear. So aside from the manual staining, we can also have automated slide stainers like this. So you just put your slides there and your stain, and they can stain your slides uh, as fast as, I don't know, 30 seconds or so, or 1 minute. Okay. Now we go specifically to the different blood cell components. So we go first to our erythrocytes or our red blood cells. So as we have mentioned, they are circular and homogeneous disc. They're about 6 to 8 microns in diameter. But of course, they can vary if there is a disease using the hemoglobin content and also to their size, shape, staining properties, and structure. Okay, for this picture, so this is a normal RBC with a central pallor. No? The central pallor is about 1/3 of the size of the red blood cell. So that if it's more than 1/3, then you will consider a hypochromic anemia. So how will you know? Just looking at this picture, if it's the size of your red blood cells is normal or not, if it's microcytic or macrocytic or normocytic. So when you have a lymphocyte, this will be your basis so that the nucleus of your lymphocyte will be the same as the size of your red blood cells. Okay. Next, we have the color. Um, so depending on the hemoglobin content, the depth of staining. So this is just a rough guide to the amount of hemoglobin in your red blood cells. Actually, in your EDTA tubes, you can already um, have an initial diagnosis now if it's anemia. So lesser yung hemoglobin content if it's bright pink. And of course, when you do your staining, it will be lighter compared to a normal hemoglobin patient. So hypochromia, when there's a low hemoglobin, have larger and the central pallor is larger, no? And they have usually a low MCH and MCHC as compared to our hyperchromia. So this can be our hyperchromia. It increases, there's increased MCH and a normal MCHC as seen in cases of megaloblastic anemia. So in here, the red cells, so this can be a macrocytic red blood cell that lacks central pallor. So it's actually a mixture of your microcytes, normocytes, and even macrocytes. Another condition that is significant in the evaluation of erythrocytes is the spherocytosis. So these are hyperchromic, there's no central pallor, spherical cells. So in here, there's normal MCH with increased MCHC, and they're often small with eccentric pale area. This is found in hereditary spherocytosis, autoimmune hemolytic anemia, and even physical or chemical injury to cells. Next, we have the anisochromia or dimorphic anemia. So this is when you see a dual population of hypochromic red blood cells and normochromic RBCs in the same film. So this is a characteristic of sideroblastic anemia, even in iron deficiency anemia after iron therapy, and hypochromic anemia after you transfused with normal blood cells. Next, we have polychromatophilia or polychromasia. These are bluish to grayish tint to the red cells because of the presence of RNA. So this is seen in our reticulocytosis. So these are actually reticulocytes as you see it in the peripheral blood. And this can be an indication of hemolysis or acute blood loss. For the variation in size, we term it as anisocytosis, and it represents our MCV. So as I've mentioned earlier, if it's less than 80 femtoliters, it can be classified as microcyte. If it's more than 100, are the macrocytes. Now, there is also, when there's variation in size, there's also variation in the shape of the red blood cells. So for the variation in shape, we term is at poikilocytosis. Or in megaloblastic anemia, you can see different variations in the shape of our red blood cells. They can have oval, pear-shaped, teardrop, saddle, helmet, or irregularly shaped. And in this picture, this is actually an elliptocytes. So some are ovalocytes, but to differentiate oval from elliptocytes, they are like more oblong, no, compared to the ovalocytes. And this is more significant because this is associated with hemolytic anemia, but still normal persons can also have elliptocytes up to 10%. And associated conditions includes iron deficiency anemia, myelofibrosis with myeloid metaplasia, megaloblastic anemias, and sickle cell anemias. Another variation is the target cells, or also known as the leptocytes. So as you can see here, there is a peripheral rim of hemoglobin with a dark central area. Okay, so we have a common term for this, parang top view of a man that is wearing a hat. No, kasi meron siyang dark central area. So this is seen in obstructive jaundice because of the augmentation in the cell membrane, or also among post-splenectomy patients because there is a lack of normal reduction of the surface membrane as the cell ages. Also seen among chronic anemias such as thalassemias and hemoglobin C disease. Another one is the schistocytes or the cell fragments. So it indicates the presence of hemolysis as seen in megaloblastic anemia, severe burns, and microangiopathic hemolytic anemia. So in microangiopathic hemolytic anemia, there is either the patient has small blood vessels or there's a fibrin in the blood vessels that will lead to intravascular fragmentation of the red blood cells. So pag daan nila doon sa maliliit na blood vessels, they will be fragmented. So it's like a helmet or Burr cells. These are irregular cells with prominent spicules. You can also have these tiny bits of membrane as seen in a thermal injury. They're also fragmented cells. Another one is the acanthocytes. So these are irregularly spiculated red blood cells in which the ends are bulbous or rounded. So unlike yung mga crenated cells, no, that are sharp edges. So this is specifically important for cases of abetalipoproteinemia, which can be hereditary or acquired liver disease. Another one is the echinocytes or the crenated cells, though they are commonly occur as artifacts during preparation of films or due to hyperosmolarity or to the discocyte echinocyte transformation, which decreases the ATP in the red blood cells. So these are echinocytes. Okay. So other artifacts that can be seen in the red blood cells, we have here the basophilic stipplings, and then we have here also the Hubble-Jolly bodies, which are remnants of nuclear chromatin in post-splenectomy and hemolytic and megaloblastic anemias. So this is agglutination of your red blood cells. In comparison to our Relu formation. So actually, hindi siya pa siya masyadong Relu, no? Only up to 2 to 3 red blood cells. But in some cases, you will see na up to 5 or more stacking of RBCs. So that is to differentiate Relu from agglutination. And then in here, we have the nucleated red cells or the normoblasts, which are immature red blood cells. So we have also maturation series from our red blood cells. So this is actually enucleated red blood cells, and this could be a orthochromatic normoblast. Now, we will proceed with the WBCs and the peripheral blood smear. So for the leukocytes, we will only tackle the 5 main components of our white blood cells, no? The normal WBCs. So you remember yung acronym natin for remembering which cell is yung pinakamadami to the least WBCs in the blood. So you remember it now. So for, of course, the neutrophil, also known as the polymorphonuclear cells, or the segmented neutrophilic granulocyte, is the most abundant among our WBCs. And this is about 12 microns in diameter. They are smaller than monocytes and AOs, but slightly larger than the basophils. So they can be, the nuclear segments can vary from 2 to 5, but in average, they are 3. So they can have the letters E, imagine lang, S, or Z. This is actually bonds. 1/3 of its granules are azurophil granules, and 2/3 are specific granules. The reference is about 1.8 to 7 times 10 to the 9. We also have here the band neutrophils when the chromatin is U-shaped. There's no fine chromatin that differentiates it from the other nuclei segment. And when there is increased in the number of our band neutrophils in comparison to the number of mature neutrophils, then we will consider a shift to the left, which can be an infectious process or a myeloproliferative process. So we can also see here a giant platelet. So this is not an RBC, no, this is a giant platelet. Next one is our eosinophil, an average of about 13 microns in diameter. They have a similar structure to our neutrophils, except for the presence of the bright red granules. So they have a colorless cytoplasm, but the nucleus can vary from 2 to 3 segments, but rarely 3. Mostly are 2. This is reference values up to 0.6 times 10 to the 9. And another one is our basophil, or the basophilic granulocyte. In here, it resembles also the neutrophil, but the nucleus is less segmented. It has larger granules, which has a strong affinity for basic stains. These granules are also soluble in water and can have a mauve to deep purple color. And they are the least numerous with an average of 0.5%. So actually, the reference is 0 to 0.1 or 0.2 times 10 to the 9. Another leukocyte is the monocyte, and this is the largest cell of normal blood. They have a single nucleus, partly lobulated or deeply indented, and also have horseshoe shape with an abundant cytoplasm. So another clue for identifying monocyte is the presence of its population and fine granules. Next, we have the lymphocyte. These are mononuclear cells without specific cytoplasmic granules. So this is about the size of our red blood cells, about 6 to 10, with single sharply defined nucleus. Okay, so this is a megaloblast with a large nucleated red cell with an abnormal open nuclear chromatin. So these are the chromatin. So they are frequently seen in myelodysplastic syndrome or other megaloblastic anemias. Next one is the leukoid reaction. So this is a leukoid reaction is a term given when there is increase in the there's proliferation of our leukocytes. So there's leukocytosis with the presence of immature neutrophilic series. So in here we can see here a myelocyte and some bands. So I think you will have another lecture for the maturation series of our RBCs and WBCs. So this can be associated with infections mostly for the leukoid reaction in comparison to our leukemias and other myeloproliferative disorders. Another one is the broken cell. So this is a broken cell of the myeloid series with a ruptured cell membrane and disintegration of the cytoplasmic contents. Okay. So we can also see a plasma cell in our peripheral blood, and this is defined. They have eccentric round nucleus, so nandun siya sa dulo yung nucleus niya with a clamped nuclear chromatin and moderate amount of basophilic cytoplasm with prominent nuclear hub or a clear, this one, clear zone. So this is a nucleated RBC, and this can be a metamyelocyte. Another one is a ruptured cell. Here na nag-rupture na yung cell membrane of WBC. So this is a smudge cell, and these are basket cells. Next one is our platelets. So our platelets on the peripheral blood sphere is about 2 to 4 microns with round to oval, and they have a fine purple granules. So the center will have the granulomere, and the site for its cytoplasm is hyalomere. This is a giant platelet. Okay, so we're done with the peripheral blood. We now proceed with the bone marrow. I think we have a few slides left. So for the bone marrow examination, this can be done as an office procedure on ambulatory patients with minimal risk, and the preferred site is the posterior iliac crest. So may taas ng puwet natin. So the bone marrow in an adult is about 1,300 to 1,500 grams. And for every bone marrow examination, you should carefully examine first the peripheral blood smear, the reticulocyte count, and ESR if possible, because it is uncommon to find a hematological disease in the bone marrow without the evidence of it in a peripheral blood. So that for our peripheral blood smears that with abnormal cells, we usually suggest for a bone marrow aspirate or biopsy, and even flow cytometry or special studies. So for the preparation of the aspirate, we have the marrow films, and the presence of the gray particles actually is the best material of good films, as they serve as landmarks for the microscopic examination. We also have direct films, so imprints, itatouch mo lang yung slide doon sa bone marrow, and then we also have the crush preparation. So you put the sample between two slides and then you crush it. Then we also have special studies such as the flow cytometry and PCR studies, and of course histologic sections for biopsy. So this is what it looked like for the bone marrow aspirate. So this is the posterior iliac crest, and we use a special needle to collect the bone marrow. We have the crush preparation, wedge smear preparation, and the imprints. So for the different stains, we can use, mostly we use the right James's stain, same with the blood films. And we can also use some cytochemical stains for the differential diagnosis. This is what it looks like under the microscope. So we can have the cellular, assess the cellularity of the bone marrow together with the fat globules. So the marrow cellularity is expressed as the ratio of the volume of the hematopoietic cells to the volume of the marrow space, so the fat versus the stromal elements. So that cellularity varies with age. We usually use this formula to estimate the cellularity of a bone marrow. So for example, in an adult, this can be determined by first subtracting the age of the patient from 100, so that the range is then added with plus or minus to of that number. So for example, 70 years old na patient, so 100 minus 70, and the overall cellularity, the normal cellularity should be, so 30 yung answer, di ba? Plus minus 10, so it is 20 to 40%. So we have now the cell distribution, the normal ME ratio or the myeloid erythroid ratio. So this refers to the ratio of total granulocytes to that of the total normal blast. So for an adult, is wide range from 1.2 to 1 to 4 is to 1. So that when there's an increase in the MA ratio, we consider infection, chronic myelogenous leukemia, erythroid hypoplasia. And for decreased MA ratio, this can be associated with depression of leukopoiesis or a normoblastic hyperplasia. Okay. What are the indications why we do a marrow study? So this is of course to support our um, our results from the peripheral blood, and especially if we want to confirm a myeloproliferative or a leukemic processes. So this can also be used for microcytic anemia's evaluation of iron source and sideroblast, confirm megaloblastic anemia, pure red cell aplasia or myelodysplasias, and yun, reveal presence of leukemia or other hematological neoplasias. So sometimes you can also encounter a dry tap. So what is a dry tap? If the marrow cannot be aspirated, so no, paglagay mo ng syringe, you cannot aspirate anything, then that is a dry tap. So we suggest you do a biopsy. This is associated with cases like myelofibrosis with myeloid metaplasia, and also granulomatous diseases or metastatic tumor spread. So for this picture, this is a normal sideroblast with a iron granule. So this is stained with a Prussian blue. And here is a ring sideroblast with a siderotic granules that form a perinuclear ring spanning more than half of the nuclear diameter. Okay. In the lower left, we can see the normal erythroid maturation. These are the various stages of RBC maturation. This is the bone marrow. So this is a basophilic normoblast, followed by a polychromatic to orthochromatic normoblast, and then our depleted red blood cells. For the neutrophil series, so this is an undifferentiated blast to our promyelocyte. Promyelocyte exhibits the T-shape of the nucleus, and then myelocyte, the metamyelocyte, a bond, and our mature neutrophil. Here is a tissue mast cell. So these mast cells contain numerous dense dark purple cytoplasmic granules that completely covers the round nucleus. Okay. So under the bone marrow, we can see some rare cell types or normal cells. So you know, like the tissue mast cells, which are infrequent but is increased in aplastic or refractory anemia and other lymphoproliferative disorders. You can also see some osteoblast. This cell synthesizes the collagen matrix of the bone. They have a single eccentric nucleus, and this can be confused with, because of their eccentric nucleus, this can be confused with plasma cells and even myeloma cells. We also have our osteoclast. This is seen during bone destruction or repair, and it reabsorbs bone. This is associated with Paget's disease, hyperparathyroidism, metastatic tumor, a recent biopsy at the same site, and they appear as large multinucleated cells up to 100 microns. Another abnormal cell that can be seen in a bone marrow is our metastatic neoplastic cells because, as you know, the bone marrow is one of the most common metastatic sites of our tumors. And in here, they resemble myeloblasts or other primitive blasts. So how to differentiate them from our normal hematopoietic blast cells? So the clue here is they almost always appear in clusters or clamps. Okay, so that's the end of our lecture. Thank you for listening.
Thank you so much, Doc.
Thank you so much, Doc.
Okay,
Thank you, Doc.
may natutunan
Thank you,
naman
Doc.
kayo. Okay, thank you then. Um,
Doc,
we, okay, I will give na lang the copy of this presentation to Ma'am Christine and also a 10-point short quiz.
okay po, Doc. Noted po. Thank you, Doc.
Okay, sige. So thank you guys. Good
Night
night.
po.
Thank you,
Bye-bye.
Doc.
Thank you, Doc.
Thank you, Doc.
Thank you.